Hello, this is Steve Buchanan. Welcome to another live stream broadcast of a clinical case, as most of these are, as part of my two-day clinical course in Santa Barbara here. Today we have a lower molar with exceptional anatomy, really fascinating. When we look at the straight-on view in the conventional image, we can see a mesial root with very thin width, decent amount of curvature. Most of the curvature is in the coronal half of the root. The distal, we have two separate root apices. It almost looks like a double exposure. We look at the more distal angle. Here's the two distal root apices spread a little bit further, and in this view we see the two separate root apices in the mesial. Really kind of unusual. Usually you just see one root apex in the mesial, one in the distal. Here's the mesial view on the left. This is a composite view because this root has curvature, so I had to do them in two separate sections. These are really quite wide apart. The wider canals are apart in the same root, the greater chance that there is a really broad isthmus or a mid-mesial canal. So I'm going to be checking that before and after we do GentleWave in here. There is one more surprise. There's a distal lingual root. This is a mesial view of the distal root, the primary distal root, and off the side of it, with about 110 degrees of curvature, is the distal lingual root. These more often occur in second molars, but here we are, it's first molar. It's really important that you understand what this looks like from the mesial view, because your buccal view will show only a straight root. It will look straight, it'll maybe be a little bit foreshortened, but it won't show you any of this. This is one of the very few roots that you could put a brand new file in with a low torque limit and have the file break off just because you try to get it around, get it to length, not recognizing the serious amount of curvature it's having to cruise around. So we're going to be extra careful. I'm going to be extra careful when I'm shaping this, but I will be using my new Traverse files from Kerr Endodontics. These are rotary negotiating instruments. There's only 3 of them. There's an orifice widener that's a 2508. There is a 1306 and an 1806. 1306 for small canals. I'll be using that for the mesial canals and the distal lingual. Then the other one for medium and large canals, the 1806. This may be a case because it's a young patient with little or no calcification. This may be a case that only these single files are necessary to do the whole case, because we can depend on GentleWave to accomplish the cleaning without any serious opening of the canals. Basically, the shaping objective with GentleWave cases is to allow a cone to be fit and held in place at the end of the cleaning procedure. So that doesn't require a lot if you're fitting narrow cones. Here's the measurements. If we look at the straight-on view in the conventional image, we can see a mesial root with very thin width, decent amount of curvature. Most of the curvature is in the coronal half of the root. The distal, we have two separate root apices, almost looks like double exposure. We look at the more distal angle. Here's the two distal root apices spread a little bit further, and in this view we see the two separate root apices in the mesial. Really kind of unusual. Usually you just see one root apex in the mesial, one in the distal. Here's the mesial view on the left. This is a composite view because this root has curvature, so I had to do them in two separate sections. These are really quite wide apart. The wider canals are apart in the same root, the greater chance that there is a really broad isthmus or a mid-mesial canal. So I'm going to be checking that before and after we do GentleWave in here. There is one more surprise. There's a distal lingual root. This is a mesial view of the distal root, the primary distal root, and off the side of it, with about 110 degrees of curvature, is the distal lingual root. These more often occur in second molars, but here we are, it's first molar. It's really important that you understand what this looks like from the mesial view, because your buccal view will show only a straight root. It will look straight, it'll maybe be a little bit foreshortened, but it won't show you any of this. This is one of the very few roots that you could put a brand new file in with a low torque limit and have
this tooth has a composite. Let's stop the light down here. It's hard to see composites. There you can see it. Okay, so for now, I'm going to go ahead and cut my ideal access. And we're going to check under the composite and see if we have to remove it for recurrent decay reasons. When we do GentleWave procedures, we have to have a seal. If we have any carious defects under crowns or previous fillings, we'll get air leaking in, and then we don't have a negative pressure environment inside the root canal, and we don't have the same efficacy. So that's what we're looking for. Yeah, go ahead. I'm a big fan of the styrofoam bite block. They bite down in their teeth, make a little dent in it, and it really helps hold it in place. It's light. It's not slimy. Okay. So, do you have the pencil?
First door, second door on the top, on the right side, there, the top door.
Huh?
Top door, yeah.
Okay. Okay. Oh, here's a pencil. No. I don't want to use a Sharpie marker. Could you get a sharpened pencil from my office? Okay, let me just point out the landmarks we're looking for here.
Do you want a sharpie?
Huh? I want a pencil. Okay. Remember I told you in the demo in the lab earlier, you can draw on your patient's tooth. Usually you need to keep it a secret. We can do it here. So we can see the mesiobuccal cusp tip right here. Here's the mesiolingual. This is the idling cusp. You can see how far out it is over the root structure, how far in the mesiobuccal is. So if we cut in equally between these, we're going to be disappointed because we're going to be too close to this side and not far enough here. We're going to have an artificial angle to get into the MB. Now if we draw a line across here, that's our mesial wall typically. I like to stay out of the distal half of the tooth. This is the working cusp. I'm going to beat there. I'm going to be 2 millimeters away from this one. So here's my initial entry port. Actually, it needs to be cheated over this way a bit. That was too narrow anyway. Okay. It looks better unmagnified. Suction. Okay, and we're tipping this to the mesial, so we can't have a 90-degree entry from this. If we do that, we're going to have a big ledge here. I'm literally going to put my burr in the embrasure to get that angle, put this in the distal half where I'm going to start cutting. And onto that line I drew in between the mesial cusp. Through the enamel, pretty much. Time to take a close look, see if we like the design, the current position of this access. Yeah, I'm okay with that. I'm a little too conservative on the lingual, almost right to the mesiobuccal cusp tip. I'm going to keep this narrow because once I drop in the pulp chamber, I'm going to be able to use a guided burr, right? So that's going to be much easier. Back here, angled again, straight up and down buccal lingual. Let's get a little bit more light in there. This is a bad chuck. Yeah. Give another one. Here we go. Okay, I'm almost in there. We're going to take a close look at this. Make sure we still like it. Let's check that mesial angle. That's really critical. Mesial angle of the tooth, mesial angle of the mesial wall. Okay, good. Distal wall is also going to be tucked back under there. We're not cutting past the midline at the cavo surface, but we're underneath that because we're heading for the distal canal. Now, I would like a Sharpie marker if you have one. Okay. If we look at pre-op film, the pulp chamber floor is roughly where the CEJ is. And so if I'm concerned about making molar access, if I'm a neophyte especially, but it even helps pros, if I took out 30% of my challenge in finding this pulp chamber, I could do that with just a little Sharpie mark. And the way that I showed you in the lab, same here, we're going to put it at the buccal CEJ, put a mark on the drill that tells me we're not going any deeper than that. And now I have a lot less to worry about. I'm just going to worry about the X and the Y. Turn to the right for me. See if we can get a more straight-on view. The last demo we did here a couple of weeks ago, one of the comments was, hey, nice 1950s microscope. It almost is. This is like the precursor to the Pro Ergo, which is like $75K. This is $7,500 on eBay, and it has all the functionality. Kind of Spartan arms, but if you want to know why I'm doing that, I sold my Pro Ergo, missed it, and bought this back instead. So that's for the endos out there wondering about the equipment. Okay, so again, I'm at this angle. Now I'm going to use this tapered diamond because I can drop in the pulp chamber with a smaller footprint. That thing's burned. Sharpie marker. Okay. There we go. At this angle, should be a little bit better focus on this. Okay. Chris, here we go, at this angle. Really is a different experience when you have cutting grit. There I am, I'm dropping the pulp chamber. I'm done with unguided burrs. This is Kerr Endodontics LA Access burr. It's got an extended pilot tip that's 1 millimeter long and 0.2 millimeters wide. This helps me tip up line angles to have perfect line angles dropping into canals. The first part of this access act is to project the perimeter of the pulp chamber up onto the cavo surface. At this angle, in fact, I'm going to give it a little bit different viewpoint here. How are we doing on that focus? Okay. All right. You need to be able to see underneath the handpiece a little bit. So again, here's the angle. I don't need to see inside there, because there's the pulp chamber floor. You can see me coming up over the hump of the pulp chamber floor, down the mesial. I'm going to cut over to the buccal. Okay, watch please. I'll apologize for any bad video angles. It's really hard to do lower molars. That's why our preference is, we have a little pulp stone there. Pulp's really hyperemic, not any big surprise. Okay, so we have the pulp chamber floor. Let's see if I can get the tissue off of that. Here's where using a bent DG16 is so helpful. When you have the access minimally opened and you can sneak underneath there. So I know I've got a pretty good size wall still to cut up into on the mesial. I can flip it around. Here's the angle on the distal and do the same thing there. And there I am back underneath the dentin shelf in the distal canal. So now I know where I can move my burr safely. Always check and make sure you still have the tip on there. When these fail, the diamond grit is super hardy, but it will, you'll lose the tip, and that's when you need a new one. Okay. Create a mesial wall here. I'm going to go into the distal at an angle, knowing that actually the distal lingual I'm going to have to extend anyway. You don't have to have a cone beam CT, but you get surprised a lot less often when you do have one. We were talking about whether, you know, some of these cleaning systems that are expensive are worth your while. Before you get there, you need to have an imaging system. And the great thing about cone beam CT is you can use it for the rest of your practice, and of course dentistry is becoming increasingly digital. When you can marry a nice digital impression with a CT scan, that's a really that's a fun thing to do. It's really cool to send your model to the lab in an email. Okay, it's not quite as high as I remembered the pulp chamber. Let's go in here and sand the pulp chamber floor. You can see the tissue on the sides here. This is a buck 2, the Spartan tip. It's awesome for flattening pulp chamber floors in molars, sanding off attached denticles. Because once you do that, then you can see the coloration map on the pulp chamber floor better. Okay, so this is the 1. It's on about 75% power. The 2, as I said, you can put on 100%. They don't break. I shouldn't say because that's a jinx, but okay, we've got a big part of the pulp chamber yet to be unroofed here. Okay, so I'm going to tip this. Let me see if I can give you a better view. Also, I really like this double-handed mirror we have in our instrument set, because when you get into a tight spot here, you need a small one, but when you can get it, it's always better to have the larger view. So I've got to trim this lingual wall up. And at the distal extent of that, I'm going to find the distal lingual canal, right? We don't want this to go into canal orifices more than 1 millimeter on the small side. Could you feel that? Okay. Okay, let's see if we can get our instruments. There's the distal, primary distal canal, and the distal lingual is right there. So it's got a mesial, you know what, I'm not actually getting into it. Let's see if I can get into it with my angled explorer. Indeed, it's super easy because it's at an angle, right? So let's go ahead and take that little shelf off. It's easier to do the root canal than have the video angle. Okay. Be careful not to hit your mirror with your ultrasonic. It's about the same thing as hitting it with your air abrasion unit. Oh, look at this. Pulp stone came right out of there. That's why this pulp chamber appeared to be so shallow, is it was partially filled with little rocks. Yeah, we've got a much better path there now. Don't want that file stressing from a curvature in this part, because we already know it's got a major job to do going from around that buckle curve. See what's going on over here in the mesobuccal line angle. We cut across this huge wide isthmus. Watch, please. Okay. Here's the primary distal canal. You can see it's of a much larger size. I think we might have a better shot in the distal lingual now. Still a little tricky, but we've got most of that unroofed. It's going off in a distal lingual direction, strangely enough. Here's the mesial lingual. Way out there. I've got to upright that for sure. Let's see about the mesiobuccal. Yeah, I was actually concerned. This little burn mark here is LA diamond in the buccal, lateral buccal pulp horn, which we almost always see in buccal next to MB canals. So let's do the uprighting that is so helpful with this. So we'll fix the mesiolingual first. It's the easiest to see. I'm going to drop the tip of this in. I've got the outline form of the axis decently set up. And I rotate it up. Okay, that's better than using 3 gates Glydenburgs, going anti-curvature stuff. It's like, put this in there, tip it up, be done. Move on. We still have got a bunch of junk in there. Does that help? Okay, it's not totally fixed, but it's better. You know, the test is always, can I slide the instrument down and drop right into the orifice? And in fact, I can here, but I need to tip that up one more time. It's going to put too much extra angle on my my rotary files, and that's not a smart thing to do. Okay, so we've got tissue there. Let's see what we can do in this mesobuccal line angle. We're just about done with the access. Here's the primary distal canal. Here's the mesial or distal lingual. The closer we get to completion of this access, the less we should need an angled explorer. In the line angle, drops down nicely. Same thing. That's a little rough. I need to clean that up. I can be off on the side there. Here's the distal lingual. Now I've got less of a curve there. That's an advantageous groove to cut. And notice how the primary distal canal is centered between the 2 mesial canals. This is where we might find a mid-mesial. So let's open that up with an ultrasonic. All right. So remember, these canals are coming into molar pulp chambers at an angle. So when we're chasing MB2s or opening isthmuses in a mesorid of a lower molar, we're going to cut at an angle. We're not cutting it like we're going into it perpendicular to the pulp chamber floor. Definitely not. And with a round-tipped ultrasonic device, it will tend to reduce the irregularities and smooth things out. If you have anything sharp or pointy, it's going to do the opposite. It's going to make it increasingly more difficult to get into. Okay. Again, let's do the instrument test. Here's the MB line angle. I think that's going to be fine after one file gets into it. I don't want to shape deeper and cut more dentin. Let's look at the mid-mesial area. Sorry. So when you're using a microscope, you can focus a lot of different ways. You can focus by moving your mirror closer or further away, just like you can move your object, the true tooth you're working on closer or further away. You can raise or lower the chair. Okay, so I think we've got a really serious isthmus across here. We're going to find multiple little inlets here. After GentleWave happens, we'll know more about which one of those are going to open up. So let's back up a little bit. See, we've got all the canals. We've got decent openings to them. I still have a bunch of junk on this wall here. Getting used to the scope. Okay, this is why lower molars are more difficult to film. Sorry guys, this is a better view. Okay, look, using my bent DG16, I can check and see, do I have overhangs? I kind of do here in the distal lingual. I'm going to cut back in there. There's a big pulp horn under there that may still have tissue under it. So let's open that up. I'm going to start this with the LA Diamond, so we're not wasting a lot of time, and then we're going to finish it with ultrasonics for accuracy. There we go. Now it's unroofed. Looks like a big access cavity, but it's really not. She had a big pulp chamber. Okay, I'm going to straighten this up just a little bit more. In fact, I'm going to go low RPM on this. It's an electric handpiece, so I can use this as a finishing burr. And I'm opening up the little isthmus groove that I cut there. So we use these two cutting devices together. I take new ground with the ultrasonic because it has control and I can see perfectly around it. And then I take grosser amounts of dentin off with a rotary drill that takes less time. So that's getting opened up a bit. You guys let me know if we need a better focus on the 2D camera. I think that's going to be more than enough. I've got a big wall in the distal there, all my lateral stuff, maybe a little bit here. That's still that little burn mark. Yeah. I don't need to get rid of this dent and shape right here. I need to make sure there's no undercuts. Okay, so bent DG16. Let's see if there's an undercut under there. It's not much. It's tapered. I'm going to touch it with this and be done. Turn this way for me, to the right a little bit. Perfect, thank you. Okay. That's all I need to do there, I think. Now let's check it with a Bent Explorer. Cool, no underhang or overhang. Maybe a little bit right there. And this is a GentleWave consideration. Exhaust gas or vapor really needs to have an excellent and easy exit, so the Bernoulli effect is enhanced. Turn back to the left a little bit, thank you. That's an easier view, just straight down into the tooth. Turn to the right for me. Here's the distal lingual, looking right down it for the most part. There we go. And just to show what I'm talking about, can I have a 1306 vortex or traverse file? Okay. No, I'd like the orifice widener of the, okay, is that the short guy? Okay, so this is the traverse rotary negotiation set. We start with an orifice widener so we can be certain that we have a real nice final straight path. I don't use the stop, so I take them off. This is where it's really handy, for instance, with this distal lingual canal. It's got a lot of curve. Yes, I'm going to use that. We're just getting the orifices opened up. Oh, thank you. So I'm not going very far in here on this because we know that curvature starts out immediately. The distal is easy. I use orifice wideners at a little bit higher RPM. There we go. Here's the mesolingual, mesobuccal. Let's see if we can get it into some areas between there. Yeah, nothing obviously opening up yet. I'm not yet getting into that distal lingual easily with that file, but it had a big tip diameter. Okay, it's still curving out to the lingual before it makes that nasty curve back in the buccal direction. Can I have a short 15 file? All right, so that's flexing around there, unlike the 2508 orifice widener. I have no intention of going in the apical, even in the middle third. I'm just going to smooth that entry. And if you ever need to make sure that you can get a shaping file in there of a tip diameter like a 25, just do a little balanced force cut in there, and you're assured that that'll be the case. Let's go back in and see if this guy will now go in that orifice. It does. Okay, great. Okay, let's do some rotary negotiation. Okay, I can find all my orifices without looking. Turn to the right for me, please. Thank you. Okay. We're going to hook up the Root ZX3. Since it has the file lead through the handpiece, all we need to do is put the ground lead in.
Which file do you want?
1306. Actually, I'll take the 1806.
The 18.
Yes. So I'm going to set this at a mid-range of torque limit, 300 RPM.
Do you want to use the one you have there? Do you want to give any?
No, I need, no, that's an orifice widener. I need the 1806.
Yeah.
Okay. Traverse instruments have really short latch grips, so you have less room to deal with. This is a small file tip. It's only 0.13. It's actually amazing they can make these, smaller than a 1506. And it has a progressive angle on the flutes that get tighter as we get to the tip. That's the key to these small triangular files holding together without coming apart. This thing has a very sophisticated heat treatment. It's a little bit, has a little bit more remaining shape memory than a lot of these that are being heat treated. And heat treatment is awesome because it's drastically reducing our breakages. Typically, your heat treated files are going to rotate, or they're going to wind up backwards before they come apart. But you need to buy a new one then. So if you can balance that a little bit better, not be worrying about breakage. Oh, this is really smooth. Okay. Let's see if we can get the automatic on function. Apical action, auto start is on. Okay, well then it should do that. Let's see if it turns on automatically. It does. Look, it's off. That's so cool. So I don't need to switch it on. I cut apically, it turns off, I clean it. We estimated the length on this canal to be what?
Which canal are you
I'm in the mesolingual. Is that 22?
22.
Okay, so let's get 22 set up here so we know what our target is. This is the best endo handpiece in the market. Look at this. It's awesome. And using it with rotary negotiation is so perfect. I don't have to get the little lead set there. Now, anytime you're doing rotary negotiation, if you have a question about whether you're meeting a curvature you are afraid to touch with a rotary file, take an 08 file, put it in there, see what happens. That thing will have made a beautiful path for you, except for that last couple of millimeters in the root canal that may have an impediment. You may need to bend a file to get around it, or just a little file with a little bit more tactile sense. Okay, so I can also take this apex locator in the handpiece, and it has a separate file lead. If I'm using a hand file, I'm not quite there. This guy says, I am there, and exactly there. So one of the really big advantages of having heads-up microscopy is I can always put the microscope at an angle that is ideal to see that intersection between the stop and the reference point, which when I'm in the 12 o'clock position, I can't see diddly. Okay, let's measure this pup. We've got a length. So one of the tricks to rotary negotiation is, live in a state of acceptance. It's going to give you whatever it's going to give you. Some of these, the majority of these, actually, you will negotiate all the way to length. Okay, we're at 22 millimeters, almost exactly.
Which canal is that?
That's the mesolingual canal. All right, the world is round. Okay, we're gathering disparate piece of evidence. Whenever they coincide and they all fit in the same relative pigeonholes together, I'm a happier guy. Pardon? Reference point's MLCT. Let's see what happens with a 10. That was a little scratchy with an 8, so before I put a 15 there, I want a little bit more assurance that I'm not going to have a problem. Doing watch winding. So far, it's not an impediment. I got the tip of the 08 to click past there. There is a little irregularity, though. Oh, it just slipped, I think, through. Now, there are those who think that you don't have any tactile sensitivity with a rotary handpiece, and it's just not true. You got to pay attention, though. Your file will tell you, I don't want to go any further in root canal until you do something different, which is usually unload the flutes because they're cramming they're creating a super tight frictional resistance there. Okay, I'm going to put a little bend in this file. I think there's just a tiny little apical irregularity. Here's what that file bend looks like. Look, the canal's bended a little bit. Okay, we'll look down the length of the file. There's the file bend. Got the notch in the right spot. Feed the little guy back in there. Because I got that notch set up, I don't have to worry about where the file bend is. I know automatically. However, most of these canal curves in molars are to the distal direction. Yeah, there could be a serious curve in that last 1.5 millimeters. Okay. I'm going to cut just short of that with this to the 22. Let's add some lubricant. It's really nice that thing turns itself on and off. Making progress. I can feel it. Kind of has a little buzz to it when it's making good cutting action. I'm watching for the apical progress. It slows as I get to the terminus. And I don't want to hit 22. That's really as far as I want to go until I have a little bit better confidence about what's happening there with my small hand files. So I've got just a mini impediment, basically. So this is unbent. Let's see what's going on here. Also, these lower molars often have a little reverse kick to them. The canal will actually exit on the mesial surface instead of the distal. So I'm checking for that. Let's pull it out and put an impedimento bend. Okay, almost virtually a full 90. Again, I'm going to make sure I'm at 22. So I know where to, I'm going to encounter the impediment. I put it in facing the mesial, then I flip it around to the distal so I can go around the curvature. I don't know what direction it's going to need to exit, but here we are, we're getting closer to that last little millimeter. So when you bend a file that much, it's hanging on and catching in every little fin or isthmus or irregularity. So you have to kind of dance it around in there. If you feel it push back on you, don't push on it, you'll just buckle the tip of it. Now that's never, it's never a risk of breakage. None of these files, you can mash them so hard into a canal that they pigtail 3 times, they'll never break unless you rotate more than 90 degrees in a clockwise direction. All the 6s, 8s, 10s, 15s, all of you have ever broken or because you rotated more than 90 degrees in a clockwise direction. Otherwise, unless you're using crummy files or using them forever, they don't break that way. That's nice. So what that means is you can put apical pressure on them and not worry about the file coming apart. So I've got an impediment there. I don't have tug back. I have a little, feels like a little brick wall. So I'm going to pull this back and turn it in a little different direction, see if it wants to go out some, like to the distal buccal instead of the distal lingual, which it was directed towards. Nothing there, so let's go back and try in this direction. Let's check with the apex locator just to see if I'm actually there. Nope. Okay. I'm going to put a bit of a longer bend on this. This thing has a bit of mesial curve, so if I don't put that extra bend in it, the apical curve is going to not be presented in a way that can get past that little tiny irregularity there. Okay, so I've got my bent file. Oh, I feel a little tug back. That's the holy grail, right? Oh, sweet. I'm feeling tug back. Yeehaw. Man, it's not good to not be patent. I mean, people worry about slipping a file through the root canal. You are so worrying about the wrong thing. If you're worried about plugging a bunch of debris, some substrate for bacteria along with a nice little bacterial culture down there as the gift that keeps on giving. Okay. Not exactly there. I'm going to see if this tug back. Okay, it's a little looser. Trying, moving the rotating it a little bit to the buccal. Now let's go back towards the distal and mesial. And be willing to accept gifts. Sometimes when you're goofing around and they're trying to get a bent file around a curve by intention, the canal bends it and you end up going patent. So let's try a new one. Sometimes a smaller file helps, sometimes actually a bigger file will get you there. However, it's maddening when you've already been there once. Glad I got an apex locator reading though. We're like a quarter or an eighth of a millimeter from terminus, but I just don't feel comfortable without having that control. Because once you have a blockage there, it's so easy to add to it. Okay, I just felt it kind of click past. A little irregularity there. There we go. Okay. Got some work to do there. I'm going to get some shape in the other canal. Pardon? That's good. No, we're getting a signal there. If I'm pushing on it, I can't ledge the canal. As long as I'm not doing a quarter turn pull, I'm okay. I'm going to try 10. A 10 will hold a file bend better than a 6 or an 8, and sometimes that's the difference. And then if I'm totally frustrated, none of these bends or directions is working, I'm going to try a straight file. I've had cases where I could, no matter what I did to bend the file and move it through the canal, I could not get it to go patent until I put a straight file in. Feeling a little bit of tug back there, that's nice. It's these kinds of irregularities are usually a tiny little S curve. I've got tug back there. Nice. When it's loose, I'm against the impediment. Okay, I've got to bend it again. The canal is going to straighten that file out. Trying a larger bend. When we get back in the lab and I show you how to bend a file and get around that apical accessory canal, you're going to find that actually too acute of a bend will get you started into it, but then the file collapses. Having just the right radius of curvature can make the difference. Okay, I'm not going to goof around in here anymore. I'm going to GentleWave this thing, clean it, and we're going to see what fills. Okay, let's go back into the mesiobuccal canal. We don't want to cut very far before we take it out and clean it of debris. Like I did last time, and I'm glad I did that. Because of what I saw on the canal, the curvature, I stopped before meeting the impediment with the rotary file. I'm really sensitive about banging on them. Can I have some lubricant? Yeah, got it right here. Okay, let's put an 08 in there and see what it wants to do. Okay, well, it's kind of, it says I'm at length. So let's go ahead and record this while we're there. That may or may not be the case. Your smaller files are going to be less predictable with apex locators. So if you get a squirrely reading with an 06 or an 08, don't lose hope. Just go to a larger file and usually you'll get a more stable signal. So here's 20, 21, 22. We're 22 and a half. for the mesobuccal. It's kind of rare. Most of the time, mesolingual is a bit longer. Okay, so would you measure that to that length? So I'm going to make a path for the tip of this rotary file to get into. There's not a single hint of an impediment in this canal. Canals in adjacent canals of the same route can often have a very different pathway where if they're convergent, you have like this serious 90-degree curve and then a recurve the other direction, whereas the adjacent canal has a really nice, easy path. In this particular lower molar, it's the 10 file to length without a hitch in the mesobuccal canal that's making me feel really happy. Let's go ahead and put this file to length because we don't have an impediment. I don't need a 15K file there. I'm actually too lazy to do that. Here we go. Nice progress. Okay. It's struggling a little bit, so I'm going to give it some help. Let's go back to the 10, make sure we're patent. I'm sorry, the 8, make sure we're patent. Indeed we are. Okay, that's your safety blanket. Whenever you're in a really curved route like this and you wonder, is this going okay? Put a patency file in there. And I'm a millimeter patent at least. Let's see what happens with the 15. Now, the 15 often doesn't want to go to length, but it's not because of the 15 size. Look at this. So I'm a millimeter and a half short. I can wind this in a little bit, but I'm going to show you a little magic trick that will help you in all your MB2s. The MB2s, classically, you get the 6, 8, or 10 to length, and it's a bear to get the 15 there. And you can have all these. You can add 3 more path file rotaries in there if you want, but after you use an 8 and a 10, you can do half sizes. If you just take this 20K file and do the balanced force technique and get it about a ½ millimeter from length, then confirm patency with a 10K file. And see if the 15, which hung up the width of a stop, a millimeter and a half short, let's see how far it fits to length now. All the way. Your 15 file is not binding at its tip when you can't get it to length. So whatever file you're using, rotary, hand file, it doesn't matter. It's not moving, it's not advancing apically when it's activated. A bigger or smaller file, either one is a decent choice. If you get a smaller file, it'll more easily take new ground, deeper depth. And then you can take a series of files up to that new depth. Or a bigger one, like this, will make more coronal shape for the coronal 7/8 of that file, which is actually binding to be free and drop into place. So I know I've got massive curves. I don't really want my 1306 working very hard. So let's put a 20 in there and see if we can balance force it. Oh, it's already length. Okay, this guy should go right there. Sorry. Open. Thank you. Making good progress. That was an easy ½ 3/4 of a millimeter. So nice the thing turns on and off. Most of the time. Can I have some lubricant? Okay, we'll need another one. This is the 1306, right?
Yes.
First canal was in the distal was at.
No, that's 1806.
Oh.
You need 1306.
Okay. Hardy files.
So you're back to 13 now?
Yeah. Thanks, dude. We'll talk later. All right. I think somehow we'll get to length now. It should be fine. Yep, there we are, 22 millimeters. No, stop. That's kind of fun. Okay. Now that I've got that done, let's put the 1806 back in there. I'll take a new 1806. Thank you. And we're going to do the distal. Do we have a new tube of lube here?
Yes, that's
Okay. Thanks. This is the 1806, correct?
Yes.
Okay. Cool. My estimate was 23 and a half. That is the length.
For the DB.
Mm-hmm. The DB, correct. Right. Let me get just a little bit of shape here to relieve 1306. Can I have a new 1306? Okay, I'm going to go back to the distal buckle and gauge that to see what finishing file I need. Most likely I need something bigger than an 18. 1306, brand new?
Yes.
Okay, distal buckle.
It's 23 and a half.
Okay, so you've been in the MB1 of an upper molar. You've been in the DB. They're not tiny. They're not big. They're a little tiny. You had to cut your way to length. Do you want to put that file in the MB2? No. Okay, so one of the advantages of getting this file technique down to one rotary negotiating file and a single finishing file is you could afford to buy a new set of files for every canal if you wanted to. But at least don't ever use a file in the next canal when it's already been tired and you have that little thought in the back of your head, I wonder if this thing could break. The moment you have that thought, I wonder if this could break, you need to get a new file. And of all the techniques, there's like 10, 15 different tricks and techniques to limit your file breakage. That's the one that works the best. It was taught to me by a graduate student, Ernest Rillman from Tampa, Florida, amazing endodontist. And he told me after practicing 5 years in Tampa that he did not break one rotary file. And if I didn't know him, I would have thought, you are so full of beans. You know, you're like totally making up a story there. And so Ernest never lies. I said, how do you do that? He goes, you know, Dr. Buchanan, when I was in grad school, I finally realized, you know, I always had that thought right before the file broke. I had already had the thought, but I discounted it, right? So don't discount that thought. Distal lingual canal. Turn to the right for me. Thank you. All right, kids, we're pretty much mostly instrumented in. Sweet. Okay. Actually, I need to move it back there and get a lower view so you can see the reference point and the stop. Okay. And what did I have? 23 and a half millimeters by the mesiobuccal cuss tip?
On the distal lingual, yes.
Yeah, okay. Last thing you want to do with this instrument, I put a brand new instrument. What's the other thing I want to absolutely avoid? I don't want to use the file after it's plugged up with debris. Now, do you have a V-taper? Is that this? Okay. Okay, this is a really interesting file. It's made by SS White. It's got a really cool progressive taper at the end and a really small maximum fluid diameter limitation to shank in. But man, those fluid spaces are so tiny. You cut like a half a millimeter, they're all plugged up. They plug up so tightly that you have to use a burr brush to get the debris out of there. So that's not good. I want the flutes at the shank end to be open so they carry more debris, so they cut more effectively. I want them to be tightened up at the tip so that they have a shearing direction of cutting. They're less likely to hang an edge, and because we stack up more of them closer together, we have more metal mass there. While we also achieve, weirdly, at the same time, increased flexibility. So here comes the next. We're getting close. Okay, turns out it's 25.
And your reference point.
Reference points, mesiobuccal cuss tip. let's just gauge that, because I feel that would really cheer me up if I found out that that was all we needed to do there. Okay, here's a 10K file. 23.5 is pegging the stop. Sweet. Let's see what the 20 does. Oh, shoot, we got to get a bigger file up there. Let's see what happens with a 30. Really didn't want to do a 30 to length, but okay, that's it. Whoever said life is fair. Okay, so I'll take a 3004. And we're gonna lose the lubricant because I've been to the end of all these canals. Okay, still got a little work to do in the mesolingual. Suction, please. We're very close to being ready to clean and fill this root canal system. Hmm?
Open, Gloria.
Oh, okay.
Open wider. And bite down. Mark. You okay there?
Okay, EDTA. Let's take a little bit of a look down there.
Check it.
Sorry, thanks. Okay, we've got nice round shapes. Our file paths, I think, are good. I'm going to need to gauge and increase that distal root. Let's actually do that first. So I'm not in the mood to get a 30 something in the distal lingual yet. Okay. Distal canal length is what?
Distal bulk is 23.5 and length is 25.
Okay. So 20 slips through, expected that. 30 binds at length. Let's see if the 40 steps back. The 40 steps back 1.5 millimeters, so there's very close to a 06 taper there already. I'm going to irrigate. We're going to put a 30-06 file to length.
You have an 04 there.
Okay. 30-06 would be great. Is this at length? Our length is 23.5 here?
Yes.
Okay. Okay. All right, distal canal shape, final shape. I love that feature. Okay, and it stops. Where am I seeing the debris? I'm seeing the debris near the tip. That's encouraging. Let me put a little bit more EDT in there. We're a little light. Okay, 30-06, back into the distal primary root canal, and I'm to length. Do I have debris at the very tip flutes? I believe I do. It's light and they're translucent, but gauging will tell the story. So let's see if a 30 still binds at length. I'm going to use the 20 first to clear and make sure I'm patent, because if I cut anything in there, I've likely left debris. Okay, here we go. That's patent easily. Here's the 30. Still binding right at length, and the 40 should step back. Closer to 1 millimeter. Well, no, it was an 06, wasn't it?
Yes.
Yeah, so the 40 steps back. Oh, I need a 40.
40.
Let's see the 50. Yeah. All right, needs a 40-06. Maybe we'll see more definitive debris in the tip flutes. It's easy to talk yourself into things, right? It's like, I don't think I need another file. That must have been some debris there in the tip flutes. Okay. Don't see much debris there either. Doesn't matter. What matters is how it gauges. The nice thing is I know that those shaping files didn't go past the end of the root canal, or that thing would have just stopped. Here's the 30. It should now be a patency file. Just slightly drops through there, and the 40 is still at length. I don't want to push that little 30 through. Let's see if the 50 steps back 1.5 millimeters, and it does. The width of a stop, so we have an 06 shape with a 40-06 shape in that canal, and I'm going to get patent now. There's a patency path just to the mesial buckle. Okay.
You did 4006?
I have a 40-06 there. Let's go, let's do the MB2, or I'm sorry, the DL.
That's 25. 2018.
Yes. Where are those prototype files?
The B paper? Or
No, no, the
oh,
down here, in this, in here.
that one.
Yeah. Okay. I've got a 3006 here, a 3004, which is really what I want. $25.04. What was the length in the it was 25?
25 even.
Okay. I'm going to keep it to an 04 because of the unusual curvature. This is a, hold this, a 2504. I'm using it because I've gauged it at 30. Having a 25 tip assures me that that tip won't bind, and that's a good thing. There we go. Okay. Cleaning the file, checking it for any bent flutes. And I'm sorry, hold this. I've got to get a steeper angle here. It's not that easy to see these reference points. And we're there. Okay. No bending of the flutes. Let's gauge it and see how it looks. Here's a 15. Easily goes through. We're patent. Here's a 20. Nice. It binds right at length. And if you don't wiggle the file, you can move their head with the gauging instrument. This little guy should step back at least 1.5 millimeters. Actually, it does. Almost 2 millimeters, which is closer to a 04 taper. Let me just take a look down there, see what that canal orifice looks like. Okay. We're good to go there. So the distal canals, distal's ready. We've got 3004 in the distal lingual, 2504 in the distal lingual. We had a 4006 in the distal buckle. Let's fit cones just for yucks. You can do before or after GentleWave. Okay, so as we talked about in the lab, we're going to pre-size these feather tip cones. I've had Maria go ahead and pre-size these, so I have a stack of 20s, 30s, and 40s, which are the typical cone sizes, tip sizes I finish with. I've got nice crisp tug back here. Just grab at the reference point, pull it out. And I'm about 1 millimeter short. Okay. I'm going to take an untrimmed, I'm going to take a 3004 and see how that does. I'm sorry, 2004 and see how that does. And there you are at 25. So I want to be a 0.5 millimeter short. I might as well adjust this little guy right now. We're going to put it on 0 with the cotton pliers, put my thumb on top of it. And here's my little blade. Okay. That cone is fit. Distal lingual. Let's fit the distal buckle.
23.5,
4006. This canal length is 23.5, correct?
distal lingual,
Distal buckle.
23.5.
Okay. I'm at 22. There we go. So let's try a 30. Okay, our length is 23.5. I'm at 24. I'm going to cut this to 23. Come on. Cut. Okay. Okay, distal buckle is cone fit. And since that was so fun, we're going to do it again. It's so sad we can't do the 15-second rule. I'm sorry, 5-second rule. They're small, you have to find them first.
Here's a new one.
Hmm?
Here's a new 50.
Oh, okay. You even got a perch that can dull a blade. Of course, these are pretty cheap blades, too. All right, there we go. Do not misclip this little guy. There we go. You always want to make that little pinch mark so you know where it should go to when you cement it in place. If you don't know that, you could be misfit and mis-cemented and then condense it and have to retreat the whole thing. Okay, so let's try to fit the mesial buckle. What do we have there?
We use a 1308.
Oh, okay, let's gauge that. Sorry.
Start with the
So MB canal length?
22.5.
22.5. Let me have a 15 first, please. Just checking dimensions. I got to know what everything looks like in there. So when might I still use carrier-based obturation now that bioceramics have made it so easy to do 3D continuous wave in its abbreviated form? The answer is that mesolingual canal. There's a patent path through there. I just can't get the file through. I may have dinged it a little bit with my 10K file. Okay, so that slips through. Here's, I have some EDTA. This is fitting a millimeter short. I'm leaving it at a 1306. I think that's a good shape for that MB canal. Okay. MB is a 1306, yeah. So I'm going to fit a feather-tipped one in there. But that was an 06, right? We didn't have an 04 on that.
No.
Cool. Okay. If you've been fighting that access, that little bump on the orifice, here's the time it's going to really mess you up. You need to go in there and just fix that little guy before you obturate, because it will catch the tip of your cone when you have it all coated up with sealer. You can't tell where the tip exactly is. Okay, let's get, and remember, we're fitting cones only in wet environments, wet canals. If we dry that out, we'll get false tug back, and the cone will easily slide another millimeter. Okay, our length here is what, 23 and a half?
MB 22 and a half.
22 and a half. I'm at 23. I'm so happy. So 22 and a half. Yeah, it's like I got everybody watching, you know. It's different if you're struggling to fit a cone and, you know, you're boring your dental assistant. Occasionally, I have my assistant leave the operatory because the aura of boredom interferes with my concentration. It really does help, and I don't blame her at all. It's really boring watching somebody pick to length in an MB2 for 45 minutes. Okay, so MB's fit. These are all cut back to be their ½ millimeter ideal self. Okay, let's go in and
Why are you cutting half short than the actual one?
because if I leave them at length, they're a ½ millimeter long when I finish. Just empirical. So here's the deal. I'm fitting it. It's a wet environment, so it's closer than a dry canal to the right environment. But sealer's actually more slippery, and I'm putting a downward force on it, so it's just going to wedge in like a cork in a bottle. And it's just like, if you're getting down to 04 tapers, as I said, though, don't cut back a little bit more, because they're going to slide a little bit more depending on the curvature. That ML canal, nothing was going to slide ever through the end of that. Let's put some EDT in the canal and see if we can't get a bit more patent. What? Okay. Okay. Length is 22?
22, yes.
Okay. Now, you know these little length marks on here are, the one by the file flutes is 18, 19, 20. I'm at 22. There's another one, 24, right under that stop. And sometimes in these smaller instruments, because they're so hard to see the tips without magnification, it's easier to set by those length marks than it is to do by sighting the tip on a ruler. Okay, so here's that canal I'm having a little bit of trouble with. Oh, little catch there. I'm feeling tug back, which is really a happy thing. There's just an Arlutes reverse curve here somewhere. Okay, I'm going to leave that alone. I'm going to put a carrier in that one. Perfect indication. Okay, let's get ready to make a platform. Turn to the right for me. Yeah. So basically we're creating a custom gasket around this tooth so that we can create a negative pressure environment. We're going to scrub these tooth surfaces with alcohol swab. This is really important. A lot of us starting out using this had trouble getting the platform to stick, and we're trying all these things. Some people are air braiding teeth and crowns and stuff. Trying different glues. There's somebody that actually crazy glued them on because they think that's just like going too far because you got to get the thing off at the end. And it turns out there's still a film after you air water syringe. There's still a film on the tooth surface. You scrub it with alcohol, everything sticks nicely. Also, they said it helps to have adjacent teeth. Were you able to find the filter?
I did.
Awesome. That was harder than it had to be. Okay. Here we go. Yeah, you don't want to be cheap. With this, you want to use more than enough, because every tooth surface that you get a nice little tight sticking to, you're going to support this thing during the process. And molars are harder to keep the seal on than anteriors and premolars by a fair bit. Okay, here's my favorite toy, latest toy. It's a plasma arc curing light. Got a need for speed. And you guys that do bonding all day long, why don't you have one of these? Can you explain to me why you want to spend another hour a day waiting for bonding? Is that just like your little rest break? Work on meditation skills? I know you got shrinkage issues, so you got to use layers, but for this, shrinkage issues have nothing to do with the outcome, so it's super handy. All right, so we're going to put the next layer on here. I'm going to load this former up. Turn to the right a little bit. Thank you. Perioprobe, just pop this little guy up. Give it a nice curing right in the center. And it's time to trim things up. Turn the water spray on. LA diamonds are great for this. Come on. Yeah, thanks. Okay, there's a sponge in there. It'll come out with a hand piece burr. A little bit wider. Open. Great. Right there. fins hanging out. Is that a little fin right there? Let's see. Okay, that looks pretty good. I'm going to just trim this a bit more on this side. Okay, so that needs to be a funnel shape. We're going to measure the distance from to the pulp chamber floor here. You know what? Let's put a bit thicker on there. I'm going to do another. Did I lose the former? Probably. Okay. You know what? It's a little thin. Sometimes I've had an issue with that. So I'm going to just add a little bit of material right here.
Do you need another squint or you?
I'm just going to put on this. Here you go. This locking plier is a little bit out of tune. The nice thing is with GentleWave, I mean, we can finish this case in 40 minutes. I don't have to be in the operatory. I'm going to be using negative pressure irrigation, and it's going to work great. With this, I know that 10 minutes after I'm done with the instrumentation, I'm ready to obturate. So that is a nice advantage. If I have not enough thickness there, the actual gasket can kind of tear a little bit. So you learn all these things with experience. Okay. Let's measure the distance to the pulp chamber floor. Nice save. What happened? Oh.
I have
right.
it.
I don't have a cone fit there. Okay, 10 millimeters. Okay. That's not touching. I want to be a millimeter above, so I'm going to use an 8. I think the 10 was just hovering above it. This is the procedure tip for molars. This is titanium. The system degasses the solutions and puts it through this at about 9,000 psi. It comes through this little tiny, I call it the tuning fork because it's got these little struts that vibrate. And there's a curved impingement surface inside that. So the solutions come down, they jam on that, and they go back at like 45 degrees or 60 degrees. They curve back, and then that solution exhausts around the edge of this. So with this one device, they not only create a negative pressure, so that controls your hypochlorite placement, and you're going to click this little guy on, make sure it's all the way around. That's important. And then we're ready to go. It's going to do a leak check for the first minute and a half. Let's see how it goes. Did a case earlier this week that there we go, no air bubbles. That's good news. See if it stays that way. I'm gonna get a different angle on this. And I am watching that fluid flow. There we go. Every now and then you'll see a little bit of heme going up there. Anyway, I was doing a case through a beautiful crown, what I thought was going to be fine after the endo, and all of a sudden I get a huge air influx. Check it out, it had a recurrent decay in an area I couldn't see. So we cut the crown off and redid it. Okay, so we're at about halfway through the leak test. This is a distilled water routine. If you're having trouble finding an MB2, sometimes it's really, really helpful to go ahead and stage a platform and do this first minute and a half, because it'll clean all the debris out of these orifices. And when you have collagenous debris in an orifice, it looks like dentin. Yeah. Okay, so we're at 90% on the leak test. You okay, Gloria? She's snoozing on us. I always tell patients the most sincere form of compliment to your dentist is take a little nap. We're going to put a bite block in. You won't tell anybody that you snore. So we're using a hypochlorite routine now. It's a 5-minute procedure. You can choose lesser procedural lengths of time, but I'm already paying $100 for this handpiece, so I wanted to go, but if it could go 20 minutes, I'd probably go ahead and get my money's worth. So there's no air bubbles. That's totally hydrated. There's a little bit of bubble here and there. Let's get a closer look. So while it's, sometimes I need to, let's on the, yeah. Here we go. The hose is really stiff. So anyway, it's shooting the fluids back into the exhaust port and vibrating the tip of that tuning fork, which is sending the sound energy down the canals. I'll show you back in the lab. I'll show you a new video somebody shot, my friend shot in a true tooth, and it's remarkable. It cleans the smallest, most apical lateral canals first. I'm not even sure why. My best guess is because root canals act like a sound funnel. So actually the most amplified part of it is at the end of the funnel, right? So these guys picked the right energy to use to clean this, these root canal systems. It's a medical technology group in Irvine, California called LiveEndo, and their sister company kind of cured glaucoma. There's been billions of dollars spent on pharmacologic solutions to glaucoma, and these guys just designed a little micro vent that you cut a 0.4 millimeter hole in their sclera. You plant this thing there. It's got little micro claws that hang onto the soft tissue and grow over it. And basically, as soon as the pressure gets up, it just releases the pressure. There's nothing about glaucoma that's damaging except the pressure. So when people say, can they really do what they're saying they do? It's like, they cured glaucoma. I think they probably could pull this off. Here's an interesting factoid. Why did they decide to work in dentistry having no dental experience, just medical? And the answer is they looked at where we spend the most money in healthcare in the United States, and we spend the same amount on dental disease as we do on cardiology and cancer. So it's kind of like, you know, it's like the murder mystery. Who benefits, right? Who's paying the big bucks? They said, let's cure dental disease. They have a plan. I don't know how they're going to do it, but they have a plan to use this technology so that we can remove bacteria from decay instead of cutting dentin to remove bacteria. That's essentially what we're doing in these root canals. So I'm at 3.5 minutes. Nice air bubble free, just little sporadic gifts. Sometimes those are the little tissue tags coming out of the canal. I find it really hard to sit here for 8 minutes. We would have. I'm clamping it between the lower border of her jaw and the head of this thing. You can put a little bite block on them and have them bite and hold some pressure on themselves. The challenge of that is if they bite too hard, they'll rip the gasket. So one of the things that this device does, before it sends any of the solution our way, it degasses it. And it's the oxygen bubbles that are liberated with hypochlorite that cause it to be so ineffective in root canals. On a countertop, it takes 10 minutes to kill all the bacteria, spores, anything that's on there. In a root canal, it takes 40 minutes with passive irrigation. Why is that? Because there's an oxygen bubble liberated at the end of the root canal within seconds in standard passive irrigation, and that keeps the hypochlorite away from the most complex area where we need it the most. We're almost done with the hypochlorite here. And that's it. We're doing a 30-second rinse. I'm not, it is. Maria does this on many cases. I go write the treatment report while she does she cleans the root canals. I give her credit for all lateral canals that are obturated at the end. Okay, now we're doing the 2-minute final rinse with EDTA to remove the smeared layer. I might reverse that, but this is the way they have it figured out. Okay, that's about 30 seconds. Pardon? This always does the same routine. You can stop it if you want, but it's going to always start with that minute and a half distilled water leak test.
You okay, buddy? You okay?
I'm sorry, when I was cutting what?
When you were accessing the tube,
Oh,
is that just standard for you? I mean, it makes it so the mirror doesn't get all nasty.
the
Just your initial access into the tube.
okay.
You can cut dry, no water.
No, pulp's dead or dying.
Okay.
Yeah, I'm not cutting so fast that we're generating huge amounts of heat. With ultrasonic and with high-speed hand pieces, I'm going to usually use them dry. I can see better. And if I'm using them dry, she'll most of the time be blowing cold air at it anyway. Okay, that's 1 minute. We have 1 minute left. What time is it?
4:30.
One and a half minutes, 30 seconds left. $15, 10, 5. There's a 15-second rinse at the end and we're done. Almost finished with your root canal. Yay. I think they need a movie channel on the little LCD menu pad there. Okay. So to get these little guys off, usually just put a cotton plier into the front edge of it. This stuff is, this is their version of Cool Dam, and it's just really the best sealant. If you ever need to seal around a rubber dam, it's the only thing I'd use. Okay, let's take a look inside. This is always really interesting. Almost every case you're going to expect to have bleeding coming out of the canals. That's because you've pulled a negative pressure vacuum in there, and it's like you're opening up all those little capillary beds. There's nothing wrong with this bleeding. We've grown to be worried about, listen. Oh, okay. One sec. We kind of worry about bleeding because it usually meant that we created some kind of a procedural error. That's a little bleedy from in the middle there, huh? Interesting. I don't want to say I told you so, but. Orifice opener, let's try that first. I'm having a great day. How about you? 1306, please. Okay, this is an 1806.
It has numbers.
Hmm?
The first one's a 1306 that I gave. This is 106.
That's the 1306. Does it say 18?
Yes.
Come on. Sorry, I'm not used. These are brand new files. 90. Oh, 06.
18.
That's the 18. Okay, thanks. Oh, you know, I'm sorry. We need to be using the apex locator function on this. Duh. Lubricant.
Do you want me to add?
I just need to get this in. Yeah, add it after I get in here. Here, I'll take it. Let's get her more open if we can. Can we move that? Let's see here. Okay. Let's try it like this.
Open wider?
Great.
Right down?
Right down on that? Great. You okay? That's really wide. Are you okay there? That'll really help for this little part. See, I'm sighting this little mark against the outside edge of that root so that I know if I'm making an advance. I'm going to clean the flutes off, take a look. Are there any, is that unwinding at the tip? I think it is. Do we have the other 1306? They only gave me 2.
Yes. Here it is.
Okay. Can you read that, really? Good. Somebody's got to be able to do that here in this office. Okay. Can I have a 6? Almost all of these mid-mesial canals have merged with the adjacent primary mesial canal. Yeah, this thing is going in and probably turning to the right. Oh, Just get deeper? No. Okay. We're going to obturate the adjacent canals and see if we get sealer coming up there. Most often that's what's going to happen. Okay, so let's wash first. Okay, let's cement cones. Leave it wet. Let's go ahead and take a cone fit film. There's the mesial buckle. Here's the distal lingual. I love my access. It's not giving me fits. You cheat the access, you get to pay for it all the way through the procedure. And how do I know that? I only know that from sad experience when I should have known, like about 1,000 cases earlier. But that's just the way it goes for all of us. What do they say, let go or be dragged? Do I need to spend another 30 seconds to do this little thing to have the result I'm looking for? How are we doing there? Tip your chin up. Ready?
Yes.
Okay. Awesome. Oh, we are dead on. Exactly 1/2 millimeter. Can you zoom that for us, for them? Okay, we're going to put these back in with sealer on them.
You don't use the absorbent points?
Pardon?
You don't use the absorbent points to dry the canal?
I don't use a stop.
Paper points.
Oh, well, I'm going to dry the canal now. But if you dry the canal before you fit a cone, you'll never have the cone stay where it was. Yeah, that's a super big mistake. The only reason we were taught to dry canals to fit cones was because it's the only way you can fake tug back with a stop preparation. I'm serious. Nobody ever got tug back in a stop preparation without faking it. Because you can't find a cone that is like that much of a micrometer less or more to give you the right, anyway. You have scissors? Okay. All right, so they're all adjusted. Why am I doing the ML last? Is because this is hypertonic.
No, EDTA.
Okay.
Do you need some?
Let me just put a little kind of K file in here and get this cleaned out a little bit. I just put a little EDTA back in there. I'm going to just put a K file in there and see if I can disturb any debris I might have just made by putting the file in. There we go. Yeah, it's going some weird pathways there, but I'm getting tug back. I just made about a 1/2 millimeter advance into the root canal. I can always go in there and open that up if I need to. I think we're going to see it filled. That's my most common experience with this material, this technique. I have a couple of MB2s that I never touched. I knew they had a big isthmus between them, and never put a file into them. Never put a gutta percha cone in them, and they were perfectly filled with multiple ladder rungs. Okay, so let's dry canals and cement cones. Hmm?
6.
Yeah. We're going to cement the distal lingual first. So in general, cementing the distal canals before the mesial are always easier. In upper molars, I'm going to cement the distal buccal first, and then the palatal, and then the MB last. I'm going to go over here and see what our length of okay, nice. Length in that canal is 23 and a half.
GB?
Yeah. Yeah, it's drying right. Okay, it's still a little bit wet. Okay, sealer. Okay, BCHF sealer. Okay. Let me just clip this kid out of the way.
Oh, 6.
Turn to the right. Thank you. Sometimes you'll have bleeding that continues for a couple minutes. There are different remedies for that. You can put, if you put calcium hydroxide down there, that's a great cautery agent, a sealer. Caffeine works great too. You go have a cappuccino, read a magazine, go back, check it out, all the bleeding quits. Can I have some more sealer? Distal canal has a little bit more volume in it. I want to make sure that I get enough sealer in there because I'm not going to get serious and down packed within 3 to 4 millimeters of the terminus. That is not going to happen. There we go. Okay.
Oh, 6.
Yeah. Mesial buckle. The guy right there, that's the tip of a cone. That is our exact length. Sealer for the MB. Kind of downplay when you first think of it, but not having a mixed sealer is really nice. When you say, I'm ready to dry the canals, you don't wait for the sealer to get mixed. Okay.
You can use the carry.
Yeah, I'm going to cut these cones off first, though. So let me.
7.
I'll take the 70, yeah. This is a 0.7 millimeter plugger. Okay. Here I'm searing the primary palatal canal, the primary distal canal. Okay, I'm going to down pack this little guy, hopefully not very far. There we go, that's all. Not pre-bending the plugger. That little thing bent around a bit. I'm waiting to hear a double beep. Double beep there, it's been 10 seconds. If you put a little instrument here, when you wiggle this, it'll come out much easier. So that was what size of a plugger?
This is 08.
That's an 08 plugger. I've got my 08 backfill cones here. Here's how you save $4 a backfill. Sealer. And this is the technique you use to get rid of voids that you get when you use syringe backfilling. So why not start with that one, right? It's like Gow Gates. Give the traditional block, and if it fails like 30% of the time, like it does, then use the Gow Gates. What is wrong with you? Why would you use latex gloves if you could use non-latex and never think about it? I love, John Coyce has a great riff on that. It's like, God, you only have so many brain cells to think about stuff. You got to quit making all these decisions that are unnecessary. Could I have the 90 or 80? Yeah, here we go.
Coming back with the same plugger? 90.
I'm gonna have to use still have to use the syringe. It can be handy on occasion. Let's use a different plugger for this. Hold that. I'm gonna use a 1.0 plugger for the distal. You can only condense with this plugger. Can you confirm that that's a 1.0?
1.0.
Okay. And they just have them in all four of these sizes. Sealer? You know, I think I dinged that plugger. Is that it?
Yes, 10.
Sealer? Okay. We have two of the primary canals obturated now. I need the 0.9. Great.
0.9.
Yeah. This sealer, in its original form, would get really crusty with worm gut aperture techniques. And so they asked me to get involved and help redesign this so it'd be a little bit more radiopaque, about 20% more radiopaque, but mostly that turn to the right, that didn't prematurely set up due to heat. Gutta percha, when you're getting the final condensation, you want to hold a sustained condensation force because it's rubber. If you're bouncing on it, you're not getting any condensation done. Okay, I've cemented the plugger, the cone in the mesial buccal canal. I'm going to place sealer in. Let's dry the mesolingual. We're going to put a carrier in there. I prefer plastic carriers. Gutta core is nice, but it's too soft. I have every fourth or fifth one of those. I have the tip kind of get dinged. What's my length in the mesial buccal, or mesiolingual? 22.
And that was 30.
Okay, remember the marks on here. They're 18, 19, 20, and then 22 right here. I don't know if I'm going to be there. I'm going to just have that as a reference point. Because I have an impediment, I don't have to worry about stopping this at any given depth. I'm just going to slam the thing in there with a little bit of prejudice because I want to make sure I push a little bit of apical pressure and move some cedar past the terminus of that canal and make me feel more secure. Okay, so here we go, paper points. Well, that's good. There's a little blood on the tip of it. Excellent. That could be from the mid-mesial, but usually that means it's because there's apical patency. Okay. Cedar. Okay, paper point.
Need another one?
Yes. Okay, here we go. Cotton plier. Okay, so you're going to
You can open as wide as you can.
put the cotton pliers right under that stop,
Relax, relax.
bend the handle off.
You open as wide as you can.
Oh, unbelievable. Okay, and then you can heat another one up. Wow. Almost there. Jeez. Sheesh. We got a cotton lucking plier that doesn't exactly hold the lock that well. By the way, if you're futzing around here and you and this thing heats and then goes off, just reset the arm because you can't overheat these in these ovens. Okay, breaking the handle off, taking the stop off because that's not going to help me at all. And here we go. There, awesome, nice. Went to length. I'll take a preppy burr and cut that little guy off. The trick with plastic carriers is you need to know how to cut them at the orifice effectively, and it's a weird technique. Dry, you're going to put this little preppy burr, which is a non-fluted high-speed burr. You put it in a line angle, spin it up. This is 1.2 millimeters, so it matches my orifice diameter, and you're just going to crank down on that thing, and it'll cut it immediately. Usually kind of countersinks it at the orifice, too. Okay, so when you use Guttacore, there's junk everywhere. This is actually a little cleaner. She's going to hand me the plugger. Definitely want to condense that carrier. You get finished. Okay, here's the fun part.
Move your tongue towards the left.
Tip your chin up a little bit. Great.
Okay, that's
You've got to tell you, explain to your assistants the realities. Oh, nice. Okay, it had a 90-degree little hook right at the very, very tip. That's the carrier fill. Isn't that cool? How's the rest of it look? Not too bad. Let's get an angled view and see what happened. Chin up. Oh, look at that. There's my mid-mesial. I told you it had a little hook on it. Okay, a round of applause for this patient. Awesome case. Okay, I avoided professional humiliation, and you got a nice root canal. As I tell my patients, you know, when I'm talking them into this, is like, you're never going to have more oversight on somebody doing a root canal on you. Okay, cool. Not, maybe some here, I'm not sure. We're going to see, this could be a little extra right here. We're going to do a 40 by 40 small volume CT after we head over there to the lab. I'm going to show you my new air abrasion unit. This is Crystal Mark. These guys invented air abrasion back in the 50s. Did you happen to bring that mirror over? Okay. See the job right there? Okay. We're going to look at it with a microscope instead of a mirror on doing it, because it'll wreck a mirror immediately. They have some crystal surfaced mouth mirrors that air abrasion won't destroy quite as rapidly. One of the nice things about these guys is their air abrasion unit throws less sand. This little guy is really good at getting around the corner. There's another one, competing unit that's a water version, which has some big advantages because, you know, there's no particulate matter in the air, obviously. Okay. We need to do a little cleanup with the pluggers. We got a little bit of surplus there. But that's pretty clean. Yeah, the carrier looks a little bit better than the other side. Okay, so I'll take a 0.7 plugger. I have that over here. So the pluggers are really handy. You can use a plugger quite easily to cut the gutta percha at the orifice level. Let's see that happen here. Have the 0.9 ready.
It's ready.
So you always want to push the gutta percha down against itself and then remove it after that. If you have trying to get out little tissue tags of gutta percha, it really doesn't work very well. I'm having a tiny bit of trouble cutting this because it's probably connected to an isthmus there. So I got gutta percha undercut there. And my intention is to condense this so that I have a nice flat surface to get my glass ionomer against. Okay, and the distal, that's a little ragged there. You could heat this up again also. Suction. Plug it. Let's use some phosphoric etch. So usually I'm lucky enough to practice in Santa Barbara where we have an unbelievably high level of general dentistry going on, and so I'm not worried. A bunch of my colleagues will say, no, I don't let anybody else do the build-up. Most of my colleagues want to do the build-up. So what I do to ensure the coronal seal is I etch it, I place glass ionomer against pulp chamber floor and over the orifices. Then we just provisionalize it with a sponge and some composite. Okay, suction. Been using this new Voco glass ionomer reinforced or composite reinforced with glass ionomer. It flows really nicely. What's going on? Okay. I hate seeing little tiny voids right at the interface. I don't want to. It just takes all the fun out of it for me. It's like having a backfilling void. Okay, and there's my sealer, my bioceramic sealer fill of the mid-mesial canal. God, all my great. They're going to do more bonding material. Let's use the Voco. Oh, okay. This thing will cure at least 4 millimeters down. Okay, glass. So not in focus. Is that because the filter? Okay. Sponge. Just temp it.
Yeah.
I was telling him, I know you know what it is, and I know it too. But thanks. Sometimes I don't know. It's good to tell me.
Need another one, Doctor?
Nope. We want to under contour that, obviously. And I'm going to adjust the occlusion here. Now I'm done. Okay, your root canal's done. We're going to take some images. It's going to be sort of biting pressure. That's normal. It won't hurt at all anymore to hot and cold foods, so that'll make you really happy. It'll reach a peak of soreness at about 2 days. So actually, the second day it's more sore than the first day. And then I'd like to meet the guy that invented that little switch. He needed to be killed. Oh, okay. All right, you guys, this is pretty boring. If you want to go back and start happy hour, that's okay with me. I'm going to give you, I'm going to collate all the stills that I pull off the CT volume after we finish, and I'll give you a little tour of this thing, post-op tour of this thing tomorrow morning. Or I might, no, I'll do it tomorrow morning so I can hang out with you this afternoon. Okay, please, another round of applause for our amazing patient. Thank you so much. All right, we'll see you back over at the lab. Oh, look at that. Yeah, please. What is that, just composite? Okay.
That's composite.
Huh?
I think it's composite.
From the previous restoration? Do you know who's going to do your crown for you?
He doesn't know.
Okay. Can you grab that little green thing?
Oh,
You were awesome. Your tooth was really awesome too. Pull it that way, yeah. There you go.
really nice.
Hmm?
Please.
It was.
Thank you.
Did you give her dexamethasone before?
She had a shot of dexamethasone before.
She had a shot of dexamethasone?
Uh-huh.
Oh, from him?
No, a big dose.